Welcome to the Alliance for Health Reform webinar on Scope of Practice. I'm Marilyn Werber-Serafini, and I'm with the Alliance. Today we're going to be talking about the flurry of state activity on Scope of Practice legislation. The states have been working on legislation and legislation on Scope of Practice for that would decide whether advanced practice nurses, nurse practitioners, and other medical providers would be able to do more to care for patients. Due to the Patient Protection and Affordable Care Act, starting next year, millions more people will gain access to health insurance. At the same time, there are projections that there will be shortages of physicians, and in particular, primary care physicians. Our panelists today are going to give us an overview and a lay of the land about what is happening in the states regarding scope of practice, legislation, and activity in the states. They're also going to talk to us about the issues surrounding scope of practice. Before I introduce our panelists, I'd like to thank the Robert Wood Johnson Foundation for sponsoring this panel. The Robert Wood Johnson Foundation has done quite a bit of work regarding nursing and scope of practice legislation. I'd like to also point you to the right-hand upper corner of your screen where you can submit questions that I can forward on to our panelists later in the conversation. There's also a button that says webcast materials that you can click to locate our panelists' presentations and also to locate additional materials for this presentation. In addition, you can follow this presentation on Twitter, #ScopeOfPractice. A recording of this presentation will be available on our website, www.allhealth.org, today or tomorrow. We have with us today three panelists who will be talking about scope of practice. Kavita Patel is Managing Director for Clinical Transformation and Delivery at the Engelberg Center for Healthcare Reform at the Brookings Institution. She is also a practicing primary care internist. She worked in the White House during the Obama administration and also for the Senate Help Committee under the leadership of Senator Ted Kennedy. Polly Bednash has been Executive Director of the American Association of Colleges of Nursing since 1989. She chairs the Nursing Alliance for Quality Care and has been appointed to the Secretary's Academic Affiliations Council of the Veterans Administration. Reed Blackwelder is a family physician in Kingsport, Tennessee, and is President-elect of the American Academy of Family Physicians. He is also Director of the Medical Student Education Division for the Department of Family Medicine at East Tennessee State University's Medical School. We're going to start with Kavita Patel, who's going to give us the lay of the land of what states are doing legislatively on scope of practice legislation. Kavita?
Thank you so much, Marilyn, and thanks to all of you who tuned in. I'm going to go quickly through some slides that highlight work we're doing at Brookings at some of the various levels of healthcare workforce, including everything from physicians and nurses, but also looking at frontline workers and the great variability between scope of practice of frontline workers, mid-level healthcare workers, as well as something that we're going to be talking about today, physicians, nurse practitioners, and physicians' assistants. And to Marilyn's point, there could never be more state-level activity in this area because every state is under pressure to deliver on increased access, whether it's through Medicaid expansions or through the federally facilitated exchanges or state-based exchanges. The topic of workforce comes up in almost every discussion. So I'd like to briefly just highlight some top-level data and some analyses that we're doing and work at the Brookings Institution that I'll allude to in the context of these slides. So this is something that those of you familiar with workforce issues are familiar with. It's the Bureau of Labor Statistics, which to date is really our best source of healthcare workforce data, but has some limitations, and I won't spend much time on that except to show you that the projected employment in the healthcare workforce is increasing. That's a statistic, it's a fact, it's also something that underlies the President's comments that healthcare as a growth sector is an important one. In a time when we're recovering from a recession, we have an amazing job opportunity, but the question that we all ask is what types of jobs are available in healthcare, and are we actually thinking about the scope of practice of our healthcare practitioners for the demand we need in the healthcare system? This shows, this is some research done by some colleagues at the Graham Center for Workforce, sponsored by the American Academy of Family Physicians, on the geographic distribution of the primary care workforce. And I really want to just highlight the viewers to one kind of the middle column there, if you will look at it, in terms of nurse practitioners and physicians' assistants, and the differences between rural settings and urban settings. Over the last 10 years, as I showed in the previous slide, we've seen an increase in growth in nurse practitioners and physician assistants, but we've also found that there is a dramatic concentration of NPs and PAs in rural settings, large and small. The implications for this on our workforce are twofold. One, we have areas in our country where it's really hard to find qualified health professionals, and two, there is a growing workforce in terms of nurse practitioners and PAs that are serving in those settings. And scope of practice laws, active legislation in states, is supporting the efforts for independent practice of these health professionals in those states. This is a comparison. I know that we don't like to talk about money sometimes, but there's certainly an inducement of professional choice based on the perceived expectations of what you'll make when you come out of training. So I just put this, we have this slide that we put together based on some resources and other research around non-physician and physician salaries. And there's certainly a lot that drives some of these changes. There are a lot of numbers on this slide. I just want to highlight a couple of areas in terms of reimbursement for certified nurse midwives, nurse practitioners, and pharmacists, as well as on the right side, all the physician specialties, as well as a general internist, which is what I am, towards the bottom of the column on the right. And then I want to highlight a couple of state laws around Medicaid reimbursement, which affect NPs, PAs around the country. Current federal law requires state Medicaid programs to provide direct reimbursement to pediatric and family practice NPs under the traditional fee-for-service system. And some states actually pay nurse practitioners the same rates they pay for physicians for some of their services. But more than half of the states pay nurse practitioners a smaller percentage of physician rates for the same services. So once again, we're talking about doing the exact same thing from nurse practitioners and physicians, but in several states, they are being reimbursed a percentage less. This is something that's an active, ongoing conversation. Polly may allude to some of this, but I just wanted to highlight the trends. This is a more colorful slide. Don't overinterpret the red or the blue to mean anything. We just wanted it to stand out in contrast so that when you look at it, it's pretty obvious. This is a slide of National Nurse Practitioner Scope of Authority, and it may be too difficult to read, so all I'll highlight to you is to say that in the red states, physician involvement is needed to prescribe, diagnose, or treat, and in the blue states, no physician involvement is needed to diagnose, treat, or prescribe. So, and the other colored state, the teal states, are in between. So this is just to gloss over, but to show you that in our country, when we think about federal health reform and increasing access for millions, we have very different laws, and depending on if you go from one state like Texas to a neighboring state where there are different scope of practice laws, there could be different implications for the way we receive care when we're enrolling in health insurance. The other point I wanted to make on nurse practitioners is that Even all nurse practitioners are licensed in all states in the District of Columbia and practice under the rules and laws, requirements, scope of practice regs of the state in which they're licensed. Of the 26 states that require some level of physician involvement, so the red states, 11 of them require nurse practitioners to establish a collaborative relationship with a physician to ensure a means for consultation, referral, and review of provided care. And when you think about what that means and what a nurse practitioner has to do in their own practice to complete those requirements, that can often be onerous, and it can sometimes be an inhibitor to allowing for practitioners to engage in underserved areas. And then I wanted to highlight the physician's assistant's role and just kind of compare and contrast that. This is a little bit, hopefully it's a little bit more obvious to see. PAs, the issue with physician's assistants and the boundaries around their practice tend to be around dispensing of medications and the authority to do that and dispense. So it's a different conversation between nurse practitioners and PAs. We often lump PAs and NPs kind of in the same kind of bucket. I highlight this slide just to show you it's different issues. So the issues with PAs have to do with the scope of practice in their dispensing authority, and in the red states, physician's assistants do not have a dispensing authority. So I will leave it at that, and we can get into some more specific questions if there are questions from the audience about that. But for the sake of moving us forward, I wanted to actually then give you a preview of active legislation. In the 2012 legislative session, the National Conference on State Legislature tracked 827 bills to redefine providers' scope of practice in 29 states. 154 of which were enacted, and I'll highlight some of the things that were enacted in a second. As of April 1st of 2013, so just 2 months ago, there have been 178 scope of practice proposals and related bills in 38 states plus the District of Columbia. The most popular scope of practice measures in that legislation related to, and we tick off from the most popular to the least popular, were around licensure, advanced practice nursing, which is always a hot topic, midwifery, physician's assistants, and then we get into dentistry, prescriptive authority, and you can read the rest. I want to highlight some of the bills that were recently enacted. In Oregon, in June of 2013, just last month, Oregon House Bill 2684 removed certain restrictions on authorities for certified nurse practitioners to dispense prescription drugs. I offer Oregon as a contrast where in Oregon they're doing a number of accountable care reforms, great deal of Medicaid expansion. The governor has made a full-born effort to say that they're going to control total cost of care. They have a real, I think a real advanced understanding of supply and demand, and as a result of that, they've been able to drive and have some degree of success in the legislature to change and modify their scope of practice, which would have been considered generous to begin with, but to think about ways and barriers to access to care. And then I'll offer you a couple of things that have actually failed. In Nevada, Senate Bill 69 failed this legislative cycle, which would have revised provisions that would have given advanced nurse practitioners the ability to not have to do the collaborative agreements. So it's been difficult in some ways to get legislatures to strip away some of the legacy barriers in legislation. But in other cases where states feel like they have pressure and have had a governor as well as a legislature that can cooperate, we have seen a number of bills that have come through which have either expanded authority or have allowed for limited use of nurse practitioners and PAs, more nurse practitioners, independently in rural areas. So I'll stop here and just say that for us in thinking about this from an analytic perspective, the bottom line is that states are now responding to some of the pressures they feel with the expansion in health reform by thinking through meaningful scope of practice modifications, changes, yet we still face resistance between, I would say, the kind of guilds that we've created in healthcare around how we can truly collaboratively work together. Thank you.
Great. Hey. Thank you, Kavita. That was a nice overview of what exists. I'm Polly Bednash, the CEO of the American Association of Colleges of Nursing, and we represent senior colleges and universities in this country that grant baccalaureate and graduate degree nursing degrees, and we represent 98% of the institutions who educate advanced practice registered nurses, otherwise known as APRNs. There are 4 titles for APRNs: nurse practitioners, nurse anesthetists, nurse midwives, and clinical nurse specialists. And as a foundational element of this conversation, I want to tell you that all of these individuals have at least an undergraduate degree in nursing of 4 years in length, plus 3 to 4 years of graduate education in nursing as part of their training. This scope of practice issue isn't recent. It's been going on for a long time, ever since nurse practitioners have existed. And I'd like to talk today about the factual basis of the scope of practice limitations and its impact on healthcare providers. One of the first studies that was done by the Office of Technology Assessment, an entity that did studies for Congress, which is no more in place. It does not exist anymore. But that study looked at the existing research on NP, PA, and midwifery outcomes of practice and said that these clinicians could deliver 50 to 90% of primary care in a very high quality manner. So it wasn't the first or the last of these different kinds of studies about the outcomes of care by nurse practitioners and other providers. Barbara Seyfried, who was then the Associate Dean of Law at Yale University, reported in the Journal on Regulation that the removal of non-evidence-based limitations on scope of practice could dramatically improve access to care and maintain quality. In the year 2000, Mary Mundinger and her colleagues at Columbia University did a study looking at the outcomes of care delivered by nurse practitioners and physicians when those individuals had the same primary care population to follow, the same patient care responsibilities, the same requirements for productivity, and found that the outcomes were comparable. And then in 2011, Robin Newhouse and her colleagues did a systematic review of research from 1990 to 2008 and found that the outcomes, again, of care delivered by these individuals was high quality and, in fact, was safe. Well, this actually has created this growing consensus among policymakers that Kavita alluded to. This concern about who's going to deliver care has caused a number of people to come into this conversation. The National Governors Association has released a paper recommending that these scope of practice limitations be removed so that they are able to deliver care to the people in their states. The Institute of Medicine report, which recommended removal of the scope of practice limitations, was driven by the evidence, the clear evidence that exists. And the Federal Trade Commission has issued 11 state documents about what's happening in the states, recommending that the scope of practice limitations are really antitrust behaviors, and that in order to be competitive, that these states should remove these barriers, and that the care delivered by nurse practitioners and advanced practice clinicians and PAs is high quality and that can improve access to care. So we've had over 50 years of a consistent revisiting of this issue, of the same policy questions over and over, despite the continued growth of evidence regarding the quality, safety, and the satisfaction of patients with the level of care provided by these clinicians. And unfortunately, the opponents to loosening the scope of practice barriers continue to assert that the evidence is lacking. What's sad is that the opposition tends to be organizational rather than individual or local, because when you see these clinicians working together at the local level, they have very close collaborative relationships that have respect for each contributions to the care spectrum. I will say that similar evidence does not exist for the quality of care delivered by other providers. No other provider has been studied as much or delivered as much evidence about quality of care. So the microscopic assessment of nursing has revealed data and evidence that are routinely ignored. So the reality is, as you were saying, Kavita, that the care demands in this country are going to require an approach that has everyone in giving health care to the people who will be seeking that health care. Instead of trying to place barriers in front of qualified providers, we should actually be joining together and focus on having an agenda to get adequate financing for primary care, to assure that primary care services can be delivered to all of the individuals who demand that care, and that all of the providers who are capable of providing care can be engaged in a meaningful way. Now, we agree that team-based care is an effective means of assuring that all the knowledge available on a health care issue can be brought to the patient. Health care delivered by a team means that you're going to bring in multiple providers. You're going to have a pharmacist, a social worker, a physical therapist, a nurse, a physician, all working together on a team to deliver that care. And being on a team, however, does not mean being directed by others or seeking permission from others to behave in the way you've been educated to behave. It means instead sharing best practices for the patient and bringing the array of expertise available to the patient experience. One of the hottest issues that emerges in this conversation is the independent practice issue. It comes up all the time. It brings to mind the image of a nurse practitioner hanging out a shingle, sitting by his or herself somewhere without any opportunity to interact with others. In fact, very, very, very few APRNs are in what's called independent practice, and the reality is that no clinician is really in independent practice, or at least we hope not. We hope that they're all working with other providers, collaborating with that array of clinicians and professionals who can help us deliver the best care. When we talk about independence, what we mean is independence is defined as having the authority to use fully the knowledge and training that you have acquired through your studies without having to get permission from physicians or others to use that knowledge and training. Thank you.
Thank you. Before we turn to Dr. Blackwelder, I just wanted to remind our viewers that they can click on the button that says Webcast Materials to see all of the speaker presentations and also to find other materials. So, Dr. Blackwelder?
All right, thank you. Now, I agree the discussion needs to change. In many ways, the scope of practice issues are essentially distracting from what are some more important foundational discussions. Perhaps the most important point in this discussion is that states that have allowed nurse practitioners to practice without physician collaboration continue to struggle with the same problems as before. There's still primary care shortages, high costs, and fragmented care that persists. The bottom line is that while expanding scope has been proposed as the solution to the primary care needs of this country, independent nurse practitioner practice has not resolved them. The scope issues impact each state differently because of the huge variability in the education and training of NPs. We can't have an effective solution this way. We must address the need for standardized education, training, and certification of NPs first. This process varies from school to school and state to state. Depending on the state, required NP coursework and training can range from 3,500 to 6,600 hours. The 4 years is the undergraduate nursing degree. The additional time is usually only 1 to 2 years and not 3 to 4 to get the master's or doctorate of nursing. The amount and intensity of the clinical training also varies dramatically. At some institutions, parts of the training can primarily occur online rather than face-to-face in the clinical area. Accreditation can come from one of 3 groups, each with different criteria. So this lack of standardization in NP education and training means that the degree does not tell you what education or training that person has. Comparison: a family physician completes 11 years and 21,000 hours of standardized education and training, including passing exams overseen by 1 certification body. Medical school rotations give us the necessary experience to basically take care of all the range of what you might see in a patient. We get the skills and clinical training in that process. The degree clearly and consistently states the breadth and depth of training, regardless of state or school. The wide variability in education and training of NPs is profound and one of the most important issues that must be corrected. So what is the answer? It's team-based care. This is hardly a new concept. A 2011 survey found that nearly 60% of family physicians in the U.S. reported working with NPs, physician assistants, or certified nurse midwives to provide what they called a team-based model of care. In addition, the research has shown that a team-based approach to primary care can improve primary care access, ensure that patients get the full range of medical and nursing services, and have a positive impact on controlling health care costs. However, in order for America to realize the promise of team-based care, we all have to come to a better and shared understanding of what it means for medical providers to work together. As with any team structure, we need defined roles. Each team member is critical, but they're not interchangeable. Let me give you an example. One of my patients called me on a Sunday night with chest pain. He's 62, he has known heart disease, has had a bypass surgery, has reflux and lung disease. We talked. I decided it wasn't an emergency. He did not need to be seen that night. So I saw him first thing in the morning. I did more of a history. I did an exam. I did an EKG in my office, which was reassuring. It still made sense to get a stress test for him. So I set it up for the next day, and I addressed his reflux at that time. His stress test was fine. He was already better. So I provided one-stop shopping, essentially. My education and training prepared me for this. But a less trained provider likely would refer, or perhaps do more tests, or even send the patient to the emergency room. Family physicians are uniquely trained to do this work. No one else is. Much has been made of the research, as commented on. In a 2011 detailed analysis of the studies available about NP care, researchers at the University of Missouri found these studies tended to focus on a specific illness and on short-term outcomes, or on care of chronic care conditions after diagnosis by a physician. They failed to examine comprehensive primary care outcomes, which includes treatment of complex problems requiring the broad set of diagnostic skills that I get in my training. Without a doubt, NPs perform well in studies that analyze patient satisfaction. But we cannot conclude these results mean that NP care is interchangeable with physician care. The Newhouse study just mentioned supports this distinction as well. To quote it directly, the systematic review on care provided by NPs indicates their patient outcomes in collaboration with physicians are similar. Further, that same study suggests NPs provide effective care that can augment physician care and expand access to care. It did not say replace. The Newhouse article also said these study results should be interpreted carefully because of significant study limitations. In fact, several of the studies included outcomes of NPs working as part of a team or in collaboration with physicians and others. In short, these studies cannot be used to say that the care of NPs is the same as that of physicians. Moreover, the U.S. is suffering not only from a shortage of primary care physicians, but also of nurses, and an even greater shortage. As can be seen in this slide, by 2020 there will be a primary care physician shortage of 45,000, yet there will be a nursing shortage of 260,000 by 2025. Moreover, as seen here, NPs are moving away from rural practice and into specialty care, shown there. This raises an interesting comparison. NPs who work with cardiologists, gastroenterologists, and dermatologists are not seen as providing the same level of comprehensive care as those physicians. Primary care is much broader and much more complicated than is a practice limited to one organ system. NPs cannot provide the same level of comprehensive care provided by primary care physicians. In all cases, they are critical members of the team who can provide core services, but they must have collaboration with a more highly trained physician. So where do we go from here? It's time to move beyond policies that further fragment healthcare and move toward building collaborative teams that will increase access and improve quality of care. Healthcare teams that include a variety of health professionals, as we mentioned before, and are developed to meet the needs of individual communities will help us do that. Surveys show that patients overwhelmingly want coordinated team approaches to their healthcare needs with a physician leader. We're also starting to see some exciting data, and this is some bullet points. Essentially, this is showing data from practices in the Patient-Centered Primary Care Collaborative and the just-released Pioneer ACO models. This shows how team-based care is improving outcomes and lowering cost in a number of different areas. This is the answer that we're wanting to see. This is how we address the triple aim. As with any team endeavor, collaboration is key. Collaboration means the family physician, the nurse practitioner, physician assistant, among others, work together to maximize their individual expertise and skills and to provide the highest quality of care to their patients. We need to recognize that each member of the team has unique but not interchangeable skills. The discussion should not be about turf, but about how we ensure that members of a care team can work together with clearly defined and distinct roles to improve patient outcomes. Thank you.
So we've just been talking quite a bit about team-based coverage, and we are moving into an era, specifically with the ACA, of patient-centered medical homes, of ACOs, of team-based care, coordinated care. And you mentioned team-based care with the physician in charge. Would everybody else here agree that the physician needs to be in charge?
Well, I certainly would wonder what you mean by the physician being in charge. I think leaders in teams can change from time to time. It depends on what the demands for care are. There might be an opportunity for a pharmacist to lead the team in terms of the pharmacogenetics and something that's going on with the individual's care or the pharmacotherapeutics that are ordered for the individual. The notion of one individual having the training and the capability to lead is really not cognizant in terms of the varying demands of what's happening with an individual. Again, as I said before, we have no problem with the notion of a team, but if the individual who's part of that team has to consistently go to someone else to get permission to use the education and training, and again, this isn't substitutive, it's not being a substitute for the physician, it's using what you have in terms of your knowledge and skills, and if you have to constantly move to someone else to get permission, you decrease access, you put barriers in the way of care being delivered by that individual, and you increase the costs of care. There's lost time and productivity there. I worked as a nurse practitioner in a family practice residency program for a number of years, and the thing that delayed me the most was having to go to one of the family practice physicians and say, will you sign this, will you approve this? Now routinely they did that because they trusted me and knew that I was capable of making good decisions, but this constant having to move through someone else because they were in charge meant that we were really harming the flow of care, decreasing access, placing barriers, as you alluded to, Kavita.
Yeah, I think I'll just, Marilyn, because we spend a lot of time at Brookings kind of looking at accountable care organizations. I will definitely say that for we have been treating all of primary care as the same thing, and I think that's a flaw. I think that physicians should be, at least in the PCMH model or the medical neighborhood model, I think that makes a lot of sense to have physicians kind of helping to kind of lead efforts for the care of complex chronic conditions like exactly this scenario that Reed alluded to. I think we're seeing, as Polly has said, I think that for a large proportion of what we see in primary care, ACOs, medical homes, we're realizing that you probably don't even need a physician to be involved. And in fact, it might be, I've seen models with ACOs that work well for high-risk populations where a community health worker is actually kind of leading the efforts. But Marilyn, to the point you're making where dollars and kind of a huge degree of money is being spent in the healthcare system, I think we are going to see physicians really, whether it's called leading or being what they call them quarterbacks, I've heard all sorts of analogies, we're going to see physicians in those roles. But I've been encouraging, and I think Reed would agree with me, that what we need to do is have team-based care with physicians leading these efforts for where we really need a physician to be involved in the first place. I mean, I think that's, and I think the biggest debate we have is, well, what does that mean? Does that mean that if you have a sore throat, you don't really need, we start to get into a lot of kind of quibbles over, so can we send someone to see a community health worker to talk through their social determinants issues, and then a doctor really should never, because I'm not trained in that, I should never be a part of that. And I think that's where, unfortunately, we've had a lot of the back and forth. But in my mind, the drivers of the cost of care, where we really see promise in the PCMH models and the statistics you cite, I do firmly believe there's a central role for physicians in that model, but I don't think that that's applied to 100% of our care.
You know, what's interesting is if you look at the Vermont Advanced Primary Care model that they have, where you have the multiple primary care sites delivering care, and actually who's leading that primary care advanced model is a nurse, a registered nurse in the middle,
between all the sites.
Yes, and collaborating with the primary care providers to find the right kinds of resources for the individuals. And the primary care physicians who work with that team led by the nurse sits in the center love this model because it allows you to use the right kind of resources for what the needs are for the patients. If they need social services help, if they need psychological counseling, where they can be moved to. And it really then uses everybody to the maximum. It does then say that the lead in the middle is pulling all of this together. And some of it's administrative, some of it's care delivery, and it's a very different model. So it doesn't have to be a physician leading. Yes, perhaps a physician should be the only individual who manages certain types of patient populations because of the difference in their training, but there's a different model that has a nurse in the middle that's very effective in having tremendously good outcomes there.
So I need to talk about that because the words are very powerful.
Yes,
and so when you say leader, that pushes a button. When you say independent, so part of the challenge in this discussion is the moment you use a word, people pick a side, and this can't be about sides. For one thing, scope of practice, once again, has not resolved this. I don't care of the independent practice models, whatever you want to call it. States that have this kind of practice and variable versions of that model still struggle with the poor cost, or high cost, poor outcome. So I don't like getting distracted by the words, because when you say leader, it automatically says, well, who should be in charge? The reality is teams are defined variably. Communities define teams. They're not all in one building. They're not all in contract. They work together, and different people will obviously lead at different times. But the bottom line on these teams, is that it is about the best care for patients. So this isn't an administrative function solely. It's not about maximizing profit. It is about providing the best care. Somewhere in that process, I don't care how you label it, what word you use, as you said, there must be a physician involved. And permission's another one of those words, because that obviously creates a lot of restrictions. But there needs to be a point, for example, in my patient. If I wasn't involved in that care, maybe I didn't see him, but what I would like is to have a nurse practitioner, somebody see my patient, and instead of making a decision to say, well, I know how to manage this, I'm going to send this patient to the emergency room, or his cardiologist is in town, I'll send him, the call would be to me. Somewhere in there, I don't care if I'm called the leader, the coordinator, the quarterback, it doesn't matter. But at some point, a phone call to me would say, well, here's some things, let's work through this together. I might not even have to be physically in the building. So the challenge again is be careful when we use a word, because it creates an image for people. And I don't know how to define the leader of the team. A team is fluid, and a team has variable definitions. But teams and moving in that direction is where we need to have our discussion. Scope of practice, I still say, is distracting, because each state is different for lots of reasons, and each law is different, and all the energy in those laws, and it still hasn't solved the problem. What is more and more definite is team-based care. So how do we shift that discussion to moving those forward, which will involve aspects of scope and leadership? But that shouldn't be the focus. That should be the tools each state has to use to make their model work. Every state's model will be different.
But we do need to reflect, however, I need to reflect on something that you said, and you're absolutely correct that words are powerful, and it's how they get operationalized that's the concern. If you look at states where there's full scope of practice authority for nurse practitioners, we see high quality care being delivered. There may be people who are not getting access to care because there aren't adequate numbers of providers, but the care delivered by those clinicians in those places is high quality, and to assert that those individuals are harming care, which does happen in the rhetoric around scope of practice, is wrong. So let's at least start at the base with an agreement that these individuals are highly qualified, are well educated, and at some point, Reed, I know you've raised this issue in the past in other venues. I heard you on the Diane Reams show about this. We should have a conversation about your assertions that the education of these clinicians is variable and uneven. That is not true. I'd be happy to sit down with you sometime and give you clarity about that so that you could understand that and represent truth about what happens in the education of these clinicians.
So let's talk about quality and safety here, because there's been a lot written about this. So let's talk about what evidence we do have about the quality of care and the safety of patients when they receive care, both from physicians and from advanced care nurses. And by the way, after we have that conversation, we're going to talk about, we've talked a lot about the advanced care nurses, but we're going to talk about other medical professions as well. But for right now, let's stick with this, and let's talk about the quality of care and patient safety and what we know, what has been written, what has been studied. What do we know here in comparing?
Well, I did present the evidence, and it was negated. I mean, if you look at the study done by Mary Mundinger, and she's done several studies where they had comparable patient populations, comparable primary care demands, comparable accountability requirements for the clinicians, nurse practitioners, and physicians. The care outcomes were equal. So either we believe evidence, we talk a lot about evidence-based medicine, but the evidence gets ignored.
One of the challenges on that, because the moment you say research of any type, that's another powerful word. And people go, wow, there's research. Very few people, including clinicians, go and find the primary source. Fewer still have the skills to analyze, is it a good study or not? So we get kind of stuck at times, and especially in something like this. You know, one side will say this, one side will say the other. I didn't negate what you had said. There's very good evidence. It's just adding a couple of words from the Newhouse study that said, you know, the cares with collaboration is as good or even better than physicians alone. A team-based care is the way to go. Nobody works in isolation. And a lot of the Mundinger studies, a lot of those were combining things that really were somewhat apples and oranges. Some were collaborative practices, some were solo and individual practice. It's hard to generalize, but again, this can be distracting. Regardless of whatever the research says, our country is facing a crisis in terms of patients getting good outcomes, satisfactory care, and low costs. So regardless of the research, that hasn't solved the problem. And deciding which side you're going to agree with won't solve the problem. We are now getting exciting data showing that regardless of that research, the patient-centered primary care collaborative, the Pioneer ACOs, team-based care is showing improvement in the most important things, not whose research is better, not what word you use, but in actually making an impact in what we should be talking about. So I don't like to be distracted about a lot of these other issues because we're going to probably agree to disagree and it doesn't move us forward.
And again, I think teams are a very important mechanism for delivering care. We agree fully. You need to bring a number of people to the patient care delivery experience. There's no argument with you about the fact that teams are better than individuals being by themselves. It's how you define and use the language about who can practice there and how they will practice and how they can function in terms of their education and training. That's the issue. That's the fundamental thing. And we all have the same goal here. We all want to make sure that patients get high quality care, that they have access to care, that we meet the triple aim, that we decrease costs of care, and that we don't put irrational barriers in the way of anybody being able to deliver the care. Really, we have the same issues. Physicians and nurses have the same issues here about the fact that primary care is not valued. And instead of fighting about whether or not we should be able to function fully, we should be joining our forces to go after the primary care policy issues and assuring that the right kinds of resources there to support the patient-centered homes, care homes. By the way, patients don't like the notion of a medical home. They think about a nursing home. So we need another name. And in Minnesota, they've outlawed the use of medical home. It's got to be called a health home. So let's talk about patient-centered health homes, where we help people be healthy and we all work together.
So a number of our viewers want to know what patients think, what the public thinks about nurse practitioners and other providers, any provider other than a doctor, seeing them. If they call for an appointment and their physician is not available and the receptionist says, well, your doctor's not available, but you could see the nurse practitioner or some equivalent. What does the public think? What is the opinion there?
I think patients want access, they want to be able to be seen, and they want good care. Those are the most important components, and that's some of the challenge we face with patients need to see. As we have more people covered, they have to see somebody. So I think that's what patients are initially very interested in. Can I get in and see somebody? The second thing that I think comes out, and this is again a challenge depending on which research you use and what words you use, there are aspects of role clarity that I think are important. I work with medical students and residents. I've had nurse practitioners with us before. And it's very important that patients know who folks are. We teach our medical students to walk in and say, I'm a medical student, because they're wearing a white coat, they're in an office. It is so easy for a sick patient to come in and not sit there and say, by the way, before you touch me, before I talk to you, exactly, who are you, what's your education? They don't do that. They have to come in and know. And this gets into some of the other word issues, because a lot of people in this country, and more than just the health professions, deserve the word doctor. But doctor in a health home setting means something to most people. So if somebody says, I'm Dr. So-and-so, then patients are going to make an assumption that may or may not be true. And that doesn't mean that person doesn't deserve the title or that person is not a qualified and good provider, but the role clarity is another aspect that I think patients are pretty clear about. They love good care, they like care from lots of people, but they also want to know who they're seeing and who's the team. What happens if you can't provide what I need is another thing I think patients want.
Yeah, I'll just
is there data?
There is some data, and when patients are, I think Polly alluded to kind of satisfaction as well as Reed. There are high levels of satisfaction in clinical settings in which the nurse practitioner is the primary provider. There is data that supports that there's a high level of patient satisfaction. I think where we do not have as much data, but we have some kind of qualitative research and some anecdotal data that shows that labels are getting more confusing, and as advanced practice nurses have doctorates, appropriately so, are called doctor. There is a doctor confusion, and patients who have been surveyed in kind of limited settings when they are told, well, you've had a doctor, did you know that your doctor was, and this includes MDs, doctors of osteopathy, MDs, DOs, NPs, patients have said, oh, I didn't realize, what those initials meant after. They just used the word doctor, and they all assumed that meant that they went to an allopathic medical school. So we have data that supports that patients are indeed satisfied with all these different types of care providers. However, we also have data that kind of points to a state of confusion that could potentially be even more confusing when you layer in, I am Dr. Such and Such in your health home at such and such. And so I personally think that the most important research that we have yet to do is what I think maybe PCORI and some other entities in the city or in the country are doing around what is it that actually patients want, and where do they feel there is either do they perceive that there's a difference in training and what impact that might have on their quality? And then we can understand how to match our models that we're developing with what patients really truly want. And that to me is not data that we've had an abundant amount of.
Clearly every provider has a responsibility to represent themselves accurately about who they are and what their preparation is. I have to reflect back on a semi-humorous situation where our dog had to have surgery, and when we went to pick up the dog, the veterinary medical office said, you need to talk to the discharge nurse before you take your dog home. I said to my husband, you tell them that person's not a nurse. And he said, how about you have that conversation after I pick up the dog? But people use terms, and I did speak with them. They said, well, people trust nurses, and so we use the term nurse, and we use the label. So I think it's important that we use terms like, I am your physician, I am your nurse, and remove this doctor confusion by not using the term. Say, I am your physician, and I am your nurse, and help people understand that. Believe me, we do teach our students that they have to accurately reflect themselves. I have been in a number of physicians' office where the receptionist is represented as the nurse, and she or he is not a nurse. So accurate representation of who you are and the position you feel is really very important. But again, when people do get care from nurse practitioners, they are happy with the care, and they feel that they're able actually to have better communication experiences with the nurse practitioner.
Kavita, we have generally been talking to this point about advanced nursing. What about the other professions? We're hearing talk about dentistry, we're hearing talk about pharmacy.
Absolutely.
Talk to me a little bit more about what's going on in the states with legislation and what some of the states are doing to expand scope of practice in some other medical professions.
So optometry, I'll use a couple of different professions, optometry, pharmacy, and chiropractic medicine. So there are states that have active legislation around increasing the ability for chiropractors to diagnose, treat, and prescribe illnesses, for example. And we've heard a lot also about pharmacists doing more intense kind of medical therapy management and laws that can help to reimburse for those services. And right now pharmacists can do this, but they do it without any sort of reimbursement. So different states are looking legislatively as to whether aspects of therapy can be reimbursed for that type of intense chronic disease management. And I think in terms of where all of these pieces of legislation, optometry, chiropractic, pharmacy, all of them have kind of a thread in the legislation or a theme through the legislation. We want to do something. We see that there's an identified need for chronic care coordination or complex disease management, and we think optometrists who take care of diabetics have a role in doing something that otherwise they would not normally have had the scope of practice to do. I think Reed's point of having this not get buried under scope of practice is an important one. The part that's hard is that when you get to the policy-making arena, we're limited by kind of these really arcane tools, unfortunately of which scope of practice is one and reimbursement is the other. And so you see these two feeding into each other. What's interesting to me, I come from the state of Texas, and in Texas over the time from when I went to medical school there and to the present day, it's been a dramatic increase in conversations that have, I would say, liberalized scope of practice across the different professions, mostly because of a perception around being able to provide for care in underserved areas. So let me reinforce something that's, kind of Reed touched on it, that even in these areas where there's very, what we would call great parity in scope in different ways, they're still facing crises and shortages. But they have noticed in those states that there is the efflux or influx of healthcare workforce of various types. And then some of the research we're doing, some of the greatest growth areas, Marilyn, is, I hit on it again, it's not at the level of kind of the high licensure professions that are sitting here today, the nurses and doctors. The greatest growth are in some of the areas that have absolutely little to no definition around the occupation: personal home care aides, community health workers, and that is where it is growing by leaps and bounds. And it'll be really interesting, Marilyn, to see, flash forward 5 years, what conversations we have around, well, wait a minute, a behavioral community health worker shouldn't be doing those things because that's something a nurse should be doing. So it's this conversation, I think, will spread to some of the other workers we've noticed increase over the last 5 to 7 years.
The issues with the patient-centered medical home, team-based care is, again, confusing. I'm not so sure I like the health home. That sounds either like a
feel like that's
spa
more of a
or a
nursing
nursing
home,
home, too. I'm still going, I'm not feeling that one.
Perhaps we should ask patients what they'd like to have it called.
Yeah,
Exactly. I don't know if we
I
know
think
what
they just
they
want
want.
coordinated care, but whatever
don't want
the
a
word
medical
is,
home.
whatever the word is, and those are the things we get stuck with. They're kind of like our tools, just like you're saying, scope and reimbursement or payment. So those aren't great terms, but I think the key is seeing that these kinds of approaches, whatever you call them, are starting to pay dividends quickly. That's what's really impressive to me, is the Pioneer ACO in less than a year is showing some changes. The patient-centered primary care collaborative models in 2 years are showing improved outcomes, improved diabetic control, decreased ER visits, decreased U.S. Air Force. All of these things in a short time is powerful because we don't know what we're doing yet. I mean, the reality is it's just trying. They're pilots. So that, to me, is, again, where can we put our energy, realizing we still have to call it stuff. You still have to have legislation to work through it. But it reminds me, when I was in Trenton, Georgia, it was a town of 1,400. They pretty much said as soon as I showed up, you're not from around here. Because it's a small place. I was a big city boy. We were a patient-centered medical home before it was cool. We didn't have the acronym, because I was the only MD. There was an osteopath who was in his 80s at that time and winding down. There was a health department. There was an EMS station. There was a pharmacy, 2 chiropractors, and a PT.
That was it.
And that was it. But we actually were a home because we did weird things. We actually talked to each other. We didn't have EHRs then, so we actually picked up the phone. We did some things that are kind of hard to imagine right now. But we were that patient home. And even if I wasn't seeing a patient, I was kind of that next stop. Again, whatever you want to call me. Leader, quarterback, the physician down the road. But when somebody had a problem, they would call me, even a patient I hadn't seen. It's in my community. And I say, well, here's what we can do. Bring him in. I'll see him now. Or no, this one needs to go further. It was ultimately, at that point, my job to go to the next level. And that worked then. It can work now. We just have to codify it with whatever our terminology is. And again, try really hard not to get distracted on battles that don't make a difference, but say, let's find the bright spots and let's follow those. So I love hearing about some of the data you're saying, because I think that's moving us in the right direction.
Okay. Actually, the VA calls them patient-aligned care teams.
PACs,
Patient-aligned care teams.
Yeah.
We can do a survey.
A practical question. Have the changes in scope of practice enacted in 24 states and DC in 2012 been summarized elsewhere, and have any bills in 2013 been enacted?
So so I mentioned there have been some bills from the 2013 legislature that have been enacted, and I just highlighted Oregon. There's actually some, going back to my crib sheet here for just getting you the exact ones.
Is there a good place
summary,
to go to find a
National
a
Conference
cheat
of
sheet?
State Legislatures, and then we will also have one on the Brookings site. So I'll make sure you guys have access to it. But NCSL.
Also, the National Council of State Boards of Nursing has a website that does
that also,
some
I
of
think
this.
they feed in. I think that they get some of that. I think NCSL is a good home for anybody who's interested in this. In terms of impact of 2012, we don't really know kind of, well, what does this mean and translate to, well, now now we've had X percentage of nurse practitioners that can do the following compared to the year before. But we do know that, like for example, in California and Alabama, Texas, Oregon, where they've enacted legislation over the last several months, literally in the last 90 days, that there's already been kind of a push in some of these states to, one, make people aware that, for example, controlled substances can be prescribed by nurse practitioners in some of these states, et cetera. So there have been, quick on the heels of passing these things, efforts by associations to get the word out. And so that's definitely been palpable.
Okay, so one viewer from the University of Illinois is actually commenting that in Illinois, insurers seem to be, she says that insurers are more the problem than the law. She says that they are especially restrictive when it comes to nurse practitioners, more so, she says, than other states, and they often require physicians to be on site in order to reimburse for visits. She would like to know whether the federal government or state governments are doing anything to encourage insurers to panel nurse practitioners. So she's saying it's the insurers that are being more restrictive.
So,
is this common in states?
I think it really is the reimbursement in some states. But tell me, my sense is that it's really tied to the requirements for reimbursement, not necessarily for what a professional can do in that state, because that's state law.
It may be state law, but we know that there are some places where, despite the fact that the individual has the authority to behave in this way, some insurers do then put additional requirements in place or restrictions in place, and there is activity going on by the organizations to try and prevent that or overturn that. But it does occur, unfortunately. So it's a second level of decision making about who can be reimbursed and what kind of structure needs to be in place before the individual can.
But I would say that's not really.
It's not common.
It's not common,
it's
Marilyn,
not common.
and it's not something that I would say is an increasing trend at all.
No.
And there is no federal activity to mitigate it,
Right.
because I don't think it's popped up as a role for the federal government.
It does point out another member of the team are the insurers and the payment process.
Payers.
Oh,
And
yes.
Payers,
I mean, it really is an aspect that needs to be addressed, and we struggle in many ways in this country for a number of reasons, and one of them is fee for service. The model that basically says you have to do something to get paid, that's affected all of us, and it has driven up costs, it has decreased
another
outcomes.
place where we could collaborate.
Exactly. I mean,
That
this is
if there
a
is
huge
one
area.
thing, I'm in the middle for maybe an obvious reason, but I think a natural bridge. I will say to you that I think primary care, just me speaking personally in my primary care practice, we are struggling to kind of, there's this promise of a medical home, a health home, an ACO, but you're going to most people in the country, Reed, you know this, Polly, you know this, we're struggling just to figure out how to do that.
Right.
And so I completely agree. We have a lot more to benefit from working together than we need to have others watch us kind of pick each other apart. And I think the team is the perfect. I can't think of anybody who doesn't want to be part of a high functioning team.
Right.
And most doctors I know, including myself, will say, I don't care what label you use on me. I just want to know that the patients that I get to see really need to be seen by me, and that the work that I'm doing isn't just in a silo, that I've got Polly down the hall and I can say, hey, I need some help downloading this, and then she can turn to me and say, I've got these two patients that I'd really like to have maybe you kind of come and see with, kind of after I see them, or however we coordinate it, and then lo and behold share data about it, because up until now we've done none of that.
Right.
And that's the
why,
truth.
That's why our energies should not be directed at preventing people from functioning fully. The energy should be directed at trying to make these systems work better, to find the ways that we can define best practices, how people can work together in the most productive ways, and how we can meet that triple aim, to get people the care they deserve and need, and have access, and to get it at the right cost at the highest quality. That's where we have a mutual agreement that we need to focus on, not the other issue about what we could or should do. It's very interesting that so many of the laws about scope of practice have been defined by where the individual sits, rather than what they bring. It's as though because you sit in a rural area, we'll let you do more, but if you come into an urban area where there's a concentration of other providers, your brain suddenly shrinks and you can't do those kinds of things. Again, let's talk about this whole spectrum of needs and focus on the things we all agree need to be done.
Yeah, the key there is we talk about the who and the where as being so important. That's where scope often focuses, rural versus urban, who's got which title. It's really how is the more important question, and that's what we're really talking about. It's hard, though. We'll have this discussion, then how do you translate that? But again, I think we're moving in that direction because we do share something. Insurance companies are for profit, ultimately, and we are for patient. And that's where we have a real chance to, again, try to find our focus to help us pull things together and then find out ways of making that team member be with the program. And the primary care challenge is huge because people talk about it, but which is great because they used not to.
They used to not.
But now they're talking about it.
I
Now we
agree.
just have to help them understand what that means,
right.
especially in terms of different kinds of services and processes.
Yeah. So we have a question here. What is the attitude of states toward allowing community health workers who are not clinically trained but licensed by some states to provide services such as diabetes self-management training? Are many states creating reimbursement codes for these services and expanding scopes of practice to allow them to support the clinical team?
No, right now, so the topic of community health workers is very relevant because there is not really a standard definition or getting back to kind of standardization of education, licensure, curricula. None of that currently exists, and I'll even extend that to something that's a lot more familiar to most people, which is medical assistants. And so these are not generally, especially specifically CHWs, community health workers, they are not necessarily on the radar for states to create definitions or standards of scope of practice. And so the diabetes self-management and some of the other programs you're referring to, which are very common more and more in the country, are generally done as kind of local requirements or resource-based requirements for the health system. And in terms of a reimbursement model, no, we do not have in place at a state level or at a federal level a code or some sort of fee that we pay directly to that community health worker, and we are not aware of any models that want to reimburse that. What we have seen, though, is an integration of the community health worker into an ACO or a medical home model, and then they're just hired as salaried or paid workers without any sort of the other financial arrangements that doctors or advanced practice nurses generally have, like bonuses for quality or performance. So but I do think that given how much of a growth area CHWs are, that there will be attention to, and you can easily see a national infrastructure or organization of community health workers that say, wait a minute, we're an important part of the team too, and we deserve some sort of mechanism for standardized approaches to reimbursement, et cetera. So I think the question is a prescient one, but we do not see any of that existing right now.
Okay, similar question about direct care workers. Healthcare is intertwined with psychosocial issues. What role do you see for social workers and community health workers? Is there any evidence, is there an evidence base for their involvement in primary care settings?
Yes, there is an evidence base for licensed clinical social workers of mental health, mental and behavioral health, as well as an evidence base for trained, I won't call them community health workers, I'd rather call them kind of trained community members. You can call it a health worker, but they're community lay members who receive some intense kind of short degree of training, not even resulting in a certificate necessarily, but training to work in conjunction with a primary care physician, psychiatrist, or a behavioral health worker, behavioral health professional, and a licensed clinical social worker in behavioral health. And in Washington State, where they've done this model and actually used a telemedicine model for doing this, they've seen dramatic increases in adherence to therapies for mental health, which is an important area, as well as a dramatic decrease in utilization of services related to other comorbidities. So let me unwonkify that. What that basically means is that in teams, getting back to Reed's point, in teams where they've had kind of community health workers or medical assistants that are trained a little bit more in behavioral health, a licensed clinical social worker in behavioral health, as well as either a primary care physician or a psychiatrist or a psychologist, they've been able to, through that team effort, been able to show reductions in utilization in conditions like diabetes and heart disease, because we've been just starting to wake up and realize that the mind and the body are actually connected, and that there is a relationship between your heart disease and depression. So there has been really definitive evidence in that area, and I think it's one of the most promising growth opportunities in healthcare. So it's a great question.
It's also huge for teams, again, talking about team-based care, because some of these issues are incredibly time-intensive yet critical. For patients' health, well-being, and life. And you and I are both trained. We can do that. We can identify someone, for example, with severe depression or a problem. We can spend time and do that. But other people can too. And when I'm spending that time, when you're spending that time, there are other things that aren't happening. And there are specific team members, if we can find ways of bringing them in. Again, they don't have to be in the same building, but we need to find ways of tapping into that. So we pick up the phone, whoever's at that point of first contact, and identify the right next step. Because this is so huge, this coordination of care, and I'm so glad you brought up mental health, because that does get short shrift in many ways in this country, and that is a key component of health, is well, how your mind works.
It also points again to this notion of what a team represents, and it represents bringing an array of skills and knowledge and expertise. I may have had training in mental health and how to identify depression. I'm certainly not capable of treating depression, and I would want to be able to reach out to the social, licensed social worker who could do that and treat in a way that would then ameliorate a number of other issues too. So that's the notion of a team, bringing a variety of people in and saying, oh, I've got to hand off to you because you're the right person for this, and that's how teams should be defined.
All right, so we have another question about collaboration. In states, and in fact I like the subject line of this one, collaboration in name only, question mark. In states, for instance, New York, where collaboration is defined as a nurse practitioner hiring a physician to review charts 4 times a year, how does that represent real collaboration between nurse practitioners and physicians? Are there problems with such an approach? And how common is this?
I'm not convinced it's very common. I think there are states where there are strange collaboration requirements about routine reviews that they have to figure out how to follow then. And perhaps that review does help the quality of care if the individual is really looking at and providing in a consultative way information that's helpful. But if it's simply to follow some pro forma expectation, it's not helpful. Unfortunately, there are laws and regulations out there that require that somebody be within 10 miles, say, to be a collaborator, to be in the same building to be a collaborator. That's not collaboration. Collaboration is consultation and conversation about the issue at hand, and then how you solve the problem, and it's bringing in multiple people. It's not routine, but it does happen, and you've probably seen that in the review of the laws that you see.
Right. Yeah. That's exactly right. It's not as I would argue that exact we start to confuse in policy kind of process with outcomes. Sitting down and reviewing charts 4 times a year, unless there's actually some kind of really thoughtful connection of what does my review mean to is there some sort of improvement activity that follows that? I mean, I'm recertified. I'm a physician and I'm recertifying myself, and I'm doing that exact same thing. I'm giving my board of internal medicine data about my care for diabetics, and at the end of it they're going to have reviewed my charts and then come back to me to tell me how I can improve my practice. That actually is a reasonable collaboration in name and in practice. But I don't know if what's happened as a result of some of these laws, which are not as many on the books as I think there may have been in the past. So I do agree with Polly, it's less of an issue, but I do think that the collaboration without tying it to some improvement activities, it's just checking boxes and not necessarily true collaboration, which is the questioner's point, I think.
And I would agree that issue with just checking a box misses the entire point. And any rule, any law can be good and can be bad. And somebody's going to manage to do either with it. For example, I could see a role, if done properly, even with that kind of a law, for someone who's newly graduated, who doesn't have a lot of experience, provided there's true feedback, even if it's chart review. It may not be, let me call and talk about the patient.
For any provider.
But even, for anybody, but especially in that setting, if it is truly a review where I sit down and there's a designated time where I say, I'm going to review X number of charts, we're going to have a conversation and go through, we're going to talk about documentation, we're going to talk about the clinical aspects, I have some questions, that would be of value. But the trouble is that gets hard because how do you build all those into the law? It's more check boxes.
So this viewer in particular would like to hear from Dr. Bednash about the educational background of advanced practice nurses.
Okay. Well, I will say again that people who are prepared as nurse practitioners have, at a minimum, a graduate degree in nursing, and it's either a master's degree or a doctor of nursing practice.
What does that mean? What kind of training do they actually go
They
through?
get their undergraduate degree, which is 4 years of nursing, and they have 2.5 years of clinical training as part of that undergraduate degree as a registered nurse. Many individuals practice for a number of years before they go on also to their graduate degree, but nonetheless, they have that undergraduate preparation. Then they have 2, 3, 4 years of graduate education, depending on whether they go part-time, full-time, etc. But the important thing I think I need to reflect on here was the illusion that there's great variability in the requirements for these programs. There is not. There is a set of standards that our organization has developed about the requirements for getting a graduate degree in nursing, and it's called the Essentials. And every school of nursing that's accredited by the Commission on Collegiate Nursing Education is required to meet that set of standards. If you are preparing somebody as a nurse practitioner, you also have to meet 2 other sets of standards, national standards that are consensus-based, that have been developed by the community of clinicians out there about what the expectations are. First, the standards for the operation of the program, and the standards for the content of the role or the population that the individual is being prepared for. Are they being prepared to do care of adults, children, women? All of those have been standardized. We've just gone through a national consensus process to standardize everything, but it should not lead people to believe that because this is a new process that it didn't exist before. We basically just codified what the expectations are that have been operationalized already. So people have a graduate degree, they meet several sets of national standards, and then they are certified by an organization which is an accredited, recognized certification organization. And that certification, either as, again, an adult or a geriatric or women's health or a pediatric nurse practitioner, provides them the authority and the state licensure to practice. So there's great standardization in what the expectations are. There should be no confusion about that.
I guess since I raised some of those questions, I was not implying that any of those processes were necessarily inadequate, but they're different. And I will say the AANP's own website has a discussion of the natural consensus need, that there, and I think it's a quote, a need for standardization hopefully by 2015, which again suggests there's been a process, and you just said that we've got a lot of these things happening. We're now pulling them together for national consensus, and that's important because that does suggest.
But it shouldn't imply that that didn't exist before.
Well, what I was saying is there are different types of processes, because is the variability in hours true? Anywhere from 3,500 to 6,600, that a nurse practitioner can have that variety.
It will depend on the population the individual is prepared to care for.
Right.
For instance, if you are prepared as a family nurse practitioner, it's a more expansive curriculum than if you are prepared as a pediatric. It doesn't mean that because someone got these many and someone got these many that they were inadequate.
No, but it does mean there's variability, and so it does determine.
Just as there is variability in medical education and residency programs, and there are multiple accreditors in medical education, and it depends on what the entity is that's being accredited.
Well, all medical students will get 21,000 hours. It's pretty darn consistent. It may miss a little bit, but it's not 15,000 to 25. Nurse practitioners will have different. Again, that's not saying it's bad, but it's different. And so the recognition that there needs to be national standards is certainly appropriate.
And there are.
Yeah, and I think continuing to move forward would be important. A lot of the graduate education, too, is different, and I really respect that a lot of the doctorate programs in nursing are really helping to design leaders, to use that word, in healthcare administration and people who are used to transforming process and doing research, and that's valuable and needed, especially in systems change. But that is different than someone who's been on the front line in a rural area practicing, seeing patients of a wide variety. So there's some differences.
Remember that the doctorate is a degree.
Yes.
It's a degree, just like the master's degree is a degree, and you can get an MBA or you can get a Master of Science in Nursing. It's a degree, it's not a role. So the degree can be provided to somebody who gets prepared for a variety of roles. But if they're prepared as a nurse practitioner, they are meeting national expectations from the National Organization of Nurse Practitioner Faculties, from our essentials, from our accrediting body, and from the certification body. So there are multiple partners. And the important thing about that consensus process is that it brought all those people together to again confirm that national set of expectations, not to discover them for the first time.
So we're getting a lot of questions about how this team-based care thing is going to work. And one of these questions is about how providers are going to be paid. If a patient is treated by a team, should payment for the services be tiered based on training, education, and/or credentials? How's that going to work?
I think Kavita has that answer, don't you?
Yeah, well, we've been looking at so it's funny because we talk about, we spend a lot of time looking at bundled payments, and just a lot of efforts in the Center on Medicare and Medicaid Innovation is around bundling of payments, which the private sector and Medicare have done before. And we're having this exact same debate about how do we unbundle payments and who gets what and how much, and that's just physicians. So we've spent a lot of time trying to think about how to move away from fee-for-service by kind of doing this team-based care, group care, et cetera. And then the big kind of question mark is how do you then unstructure these payments? Right now, those payments do flow to physicians, and then a lot of the private payers either use a proportion of that to pay other members of the team. And in some cases, I mentioned some states in Medicaid that are doing equal parity amongst nurse practitioners and physicians for services. But for the most part, what we see is some sort of distribution, with the physician getting kind of the maximum and then a percentage of the others. I think what's hard about that, one of the reasons, just even sitting in this discussion, I realize I don't think any nurse practitioner I know is trying to say that their training is equivalent to mine. I will certainly go to high horse and say there is no way the training is equivalent. The problem is that I think we've unfortunately, and it's a disservice to ourselves as professionals, we've been put into these little cages to battle each other because we've been made to perceive that we can be substituted for each other. Yeah. So when we talk about paying for team-based care, what we cannot have more of are conversations. I don't think anybody would argue that if a physician is handling the 5% of the patients that are the sickest and the most chronically ill, and they're putting in the time and the hours, then for my training and my level of experience and I didn't realize it was 21,000 hours. It felt more like 80,000 hours. I deserve to be paid a certain amount. I don't think anyone's arguing with that. I think what people are disturbed by is that we then say, well, and you're only 60% worth that health professional, so that's how much you get. But when we talk about true team-based care, Marilyn, I'll be honest with you, where we see it succeed is when people are salaried.
Exactly.
So I'm just going to cut to the chase and tell you that when we talk about moving away from the fee-for-service beast, there's this extreme, we all know the examples, Kaiser, Group Health, and that's capitation and salaries.
Well, let's talk about that a little bit,
and
because
then some spectrum in between.
Kaiser Permanente has tried this with OBGYN in areas where they have had trouble getting OBGYNs, and they have put nurse practitioners and other advanced practice to serve these areas. And I don't know, I'm hoping that some of you are familiar with this, and can you tell us, and those are salaried, it's a salaried system. So tell us about that experience and how that has worked and what we've learned from that.
I know that, I know of examples where, I don't know about the Kaiser data specifically. I know of examples where they've had certified nurse midwives as well as advanced practice nurses doing kind of OB and GYN services at salary levels, and it has helped to attract it has helped to attract access professionals who can provide those services. They are not paid the same amount that OBGYNs are, though, in those settings, and I'm familiar with some of those examples in Texas. So when they are salaried, they're not. But again, it goes back to, I don't think anybody's pretending to say that we should all make exactly the same amounts of money, and that we can have that argument. But I think all of us would agree that our different levels of training and the time for that training should be reflected in what we are reimbursed.
And I would say it should be reflected in what our role responsibilities are.
Right.
Yeah.
Right.
And
Which
then
ends
I
up
would
being how you are
also
paid.
I would also say that when we have this conversation about unbundling a team and who gets what, it does go right back to the fee-for-service model.
Right, right.
And
Just like this.
and it really, that's a model, if we really are going to give team-based care where everybody's a part of it, and we're all salaried employees, then it's less about you make more than me, and it's more about this functioning as a group that has a mutual interest in the right outcomes and mutual accountability about the outcomes, and then rewards based on those outcomes.
But right now it is going to the physician.
Is this the answer? Does everyone need to be salaried? Is that the answer?
I have no idea. But there's certainly a lot of disparities that are created by fee-for-service, and honestly, the more you do of something, the more you make, even among highly paid specialties, somebody who's doing more procedures. We have a very procedurally oriented country.
It drives the demand to
It
do
drives the
more.
demand, and
do more.
interestingly enough, going back to evidence, we're getting some evidence that many of the procedures that are being done really don't impact the ultimate outcome, which is death.
And can harm.
And can harm.
The
So
overuse issue.
there's no question that a change must happen from fee-for-service. Now, does that mean everybody's salaried? Does it mean we find another way of leveling the playing field? I don't know. But there has to be a shift, and it is happening, but it won't happen as quickly as it needs to.
Right.
And I wanted to point out, make a comment on something that you both said. I really like your saying, that physicians and nurses are not the same, and you were nodding with that, and we're not.
Right.
And I think, but what I like, though, is that I think in some ways we are being thrown in this process by others because it's also a distraction. And when legislators and when insurers have a chance, I think, to have us go against each other, it helps delay us moving forward. And I think our role is to recognize that common ground and educate. So when somebody's saying at a higher level, passing a law, that we're going to address this problem by substituting this piece for this piece, we all say, no, we're not the same. That's not the answer. The answer is this piece has to have this flexibility, this piece must have this, and then we can do some improvement. And I think a lot of it's educating people who truly are making the assumption that we're not making.
Well, we may not be the same, but there are components of our skills and knowledge that are the same, that we can do some of the same things. And I think that's where the problem comes, when there's an expectation. And I go back to what I said earlier in my presentation about what it means to be independent. Independence means being able to use your education and training and the skills you've acquired fully without having to get someone else's permission to do that. And understanding that we're different, we have different educations, we have different capacity to provide care for people is something that I think any advanced practice nurse would agree about. It happens at the direct level when we're working together side by side, and it's never really an issue in terms of that collaboration that occurs together. But understanding that the argument immediately moves then at the state level to you can't do this unless I tell you you can. That just harms the bigger conversation that we need to have about how we join forces to get the right care to people.
So one of our viewers would like to would like you all to speak about medical malpractice occurrences for physicians versus nurse practitioners. This viewer is under the impression that there are typically less suits against nurse practitioners. Is that correct, and why would that be?
Well, the data seem to indicate that there are very, very low levels of malpractice for advanced practice nurses, nurse practitioners, and midwives and nurse anesthetists. Some people say, well, it's because the deep pocket is the physician, and they'll go after the physician, and that's, in fact, where they target more than anybody. But the reality is that patient care delivered by nurse practitioners, midwives, and nurse anesthetists is high quality, and they're not experiencing the same rate of malpractice suits.
I haven't looked at the two compared to each other, but I know that recent studies have kind of illustrated in physicians and malpractice that we used to often think it was just the high procedure specialties, neurosurgery, OB, that had, and certainly those have a little bit higher rate of malpractice suits that are at least initially filed, but we're finding that it's all health professions face some degree of probability of being sued at some point in their career, including what I do, general medicine and pediatrics, et cetera. So what is interesting is that the number of people who initiate a lawsuit and then the actual fulfillment of that malpractice lawsuit has been decreasing, and there's a hypothesis that we as a medical, as physicians in a medical profession, have become more transparent and more honest about mistakes we make, something that culturally we've had to come to bear with over the last several decades. So I don't know enough about the data to compare the two. I would certainly believe the deep pockets argument to some degree, but we also know that a number of these suits really don't actually, once the medical system, like in the state of Michigan, initiates an effort to have doctors be honest about mistakes that have been made, patients drop the suits, and patients say, we just wanted someone to tell us what was really happening. So I'll say that about physicians. I don't know if, Reed, if you've seen data.
I would certainly agree that there's more and more evidence that being transparent and recognizing up front whenever an error occurs helps to decrease suits. And some of that is a shift in our culture and our process that is critical. So I haven't looked at that data in great detail either. I will say that family physicians are generally sued less than other physicians.
Yeah, that's right.
And I think some of that goes with some of the things we share with advanced practice nurses. We have a high satisfaction with our patients, good communication. It may also be, and I'm curious on the numbers, is it less suits relatively? I mean, what's the number? Because is it based on total number of practitioners for each subspecialty, or is it, one reason the numbers is, because there are fewer independent practicing nurse practitioners, there are more physicians, so is that one explanation for the number? The other might be, and it does go back to education and training, because as a physician, I'm trained to handle extremely complex cases. Those are often sicker patients. There's often more of an opportunity for a patient of that complexity to have a problem either from my care or from another team, like a consultant. And that may be another variable I would look at, because I think that will vary in some of the practices.
Well, and the large degree of suits that are, I think some either the most high profiled or the ones that have the highest dollar amount largely are attached to procedures. And so some of that right now, there's just, honestly, there's frank limitations on, I haven't met anybody who's, a nurse practitioner who's been able to, put a cardiac stent in or do brain surgery. And so since those are the suits that follow, I think that's why you're seeing what I would say is a disproportion, but I wouldn't be quick to interpret that as some dramatic statement about doctors are more negligent versus nurse practitioners. I think that kind of rhetoric just makes us kind of pit ourselves against each other rather than look at the data for what it is.
So we're coming to the end of our allotted time here. Kavita, I'm hoping you could wrap us up here by telling us, are we coming to near the end of what we're going to see in the way of scope of legislation, scope of practice legislation in the states? How much more of this are we going to see, and are we going to see this evolve into different kinds of legislation, or have we pretty much seen the kinds of legislation that we're going to see at this point?
Yeah, I think we're coming to not an end of legislation, because what would state legislatures do if there was an end to our legislation? But I think what you're seeing is now, the maps I showed you, the differences between states, while some have some really dramatic differences around independent practice issues, most states are coming around and doing things to try to augment some of these old kind of scope of practice laws and to say, let's allow for nurse practitioners to practice independently, but only in underserved or rural areas, or there's some restrictions to some of these. So I think we're seeing kind of a momentum that's peaked a bit in terms of the laws and the kinds of issues they want to deal with. What I do think is still on the horizon is that as our care models evolve and we're doing different things at the state level for what Oregon's trying to do, what Vermont has been doing, I think you'll see changes in the scope of practice that are a response to the actual changes at the delivery system level. I have now interacted with more health system leaders who have said, we are frankly tired of some of these really old practice laws that are inhibiting us from doing the following. And it's not just nurse practitioners and physicians, it's a number of licensed health professionals. So I think you'll see conversations like that drive some state legislative momentum. I think 2014 is this year where we're all kind of figuring out what's happening with health reform and what the response is going to be like. And I think if you start to see the headlines like we saw in Massachusetts when I was watching what happened in the enactment of health reform, of long wait times and problems of access increases in emergency room visits. I think you're going to see another resurgence, Marilyn, of legislation and policymakers respond. What we have not seen, but I think will see, is also kind of a national response in some way. We've had very little conversation on the federal side around licensing standardization and kind of the requirements for getting licensure in these states, which are just completely arbitrary state to state. So I think you'll also see a little bit more movement to have some standardization at the federal level, even if it's just for VA, the VA or some of the systems which are across the country.
Great. I'd like to thank our panelists for a very valuable discussion, and I want to remind our viewers that you can get more information, more materials. You can take a closer look at the panelists' presentations on our website, www.allhealth.org. And I'd like to thank you for being with us today, and to thank the Robert Wood Johnson Foundation for sponsoring this webinar.
Thank you.